Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. So, we will continue the topic of systemic hypertension. So, we'll study today the pathophysiology of arterial pressure regulation. So, to understand the to understand and to uh, precisely prescribe the antihypertensive drugs, we should know the pathophysiology of arterial pressure regulation. So, why we are prescribing, what type of drug we should prescribe to the individual which is coming to us. Okay. So, first of all, pathophysiology of arterial pressure regulation. Arterial pressure regulation involves a complex integration of renal, neural, and vascular mechanisms. Remember these things: renal, neural, and vascular mechanisms. Renal, neural, and vascular mechanisms. Okay. The fundamental hemodynamic determinants are cardiac output and peripheral resistance. So, what these three things will do: renal, neural, and vascular mechanisms. What these will do, these will alter the cardiac output and the peripheral resistance, and by altering this cardiac output and peripheral resistance, they will change the BP, SBP, and DBP. So these the effects of renal, neural, and vascular mechanisms cause changes in the cardiac output and peripheral resistance, and hence BP. So BP is nothing but, so if I write here, BP is nothing but cardiac output into peripheral vascular resistance. And remember, what is peripheral vascular resistance? It is nothing but the DBP, diastolic blood pressure, nothing but arteriolar vasoconstriction tone, arteriolar tone. Okay, so indirectly PVR is nothing but the tone in the arterioles. Okay, so cardiac output depends upon stroke volume. Sorry, what do you call? It depends upon the end diastolic volume, and end diastolic volume depends upon the preload. What is preload? Preload is nothing but the blood which is present in the veins. Okay, veins like the veins which are present in the legs. So that is also known as peripheral heart. No, peripheral heart in anatomy, which we have learned, peripheral heart. Why? Because when we walk, so the soleus muscle and the gastrocnemius muscle, mainly the soleus muscles, has large veins in it. So those veins have a large amount of blood which is present in there. So when we walk, so that is pumped to the heart because of the contraction of the muscles. That's why this gastrocnemius and soleus vessel are also known as peripheral heart, because they pump the blood, this venular blood, towards the heart. Okay, so that venular blood is nothing but the preload, and this preload depends further upon the intravascular volume. Intravascular volume, nothing but blood volume. The more the intravascular, the more you will have the blood in the veins, and this in turn depends upon the sodium concentration. Sodium concentration is nothing but the intravascular volume which is present. Okay, sodium concentration. So indirectly, BP is dependent upon this intravascular volume and sodium concentration, and peripheral vascular is dependent upon the arteriolar tone. Okay, so this we will learn first: the intravascular volume and renal sodium handling. Okay, and arteriolar tone, and this renal, neural, and vascular mechanisms will alter these things only, and they will cause changes in the BP. So let us learn this thing: intravascular volume and renal sodium handling. So normally there is something called as pressure-natriuresis mechanism. What is that? So it is important for long-term BP control. How it acts: when there is, what the kidneys do to maintain the BP at the lower side, so they excrete the sodium. Kidneys excrete the sodium. To excrete the sodium, kidney will lower the arterial. Kidney will increase the arterial pressure. By increasing the arterial pressure, the excretion of sodium is increased. When the excretion of sodium and water is increased, that reduces the blood volume and it restores the pressure. This whole cycle is known as So kidney is increasing the blood pressure in order to excrete more sodium and water in order to store the BP at the normal site. So that is known as pressure-natriuresis mechanisms. But this is altered in hypertension. That is the problem. This is altered. How it is altered? The curve is shifted to the right, meaning higher than the normal pressures are required to maintain the sodium balance. Okay, normally if, for example, for the sake of example, if 40 mm of Hg was pressure was required, now in the hypertension kidneys will require, for example, 50 mm of Hg of pressure to excrete the sodium. Why that happens? That happens because of sodium imbalance. Okay, that we learn. So role of sodium, that's why. Okay, so sodium, especially with chloride, is the primary determinant of extracellular fluid volume. Okay, so what will it will lead to? It leads to volume expansion and initial rise in cardiac output. So this is the effect of chronic salt intake, chronic high salt intake. Chronic high salt intake will lead to volume expansion, and that will lead to rise in cardiac output. So how the body responds to that? How the body responds to it? So you have learned that pressure-natriuresis mechanisms is changed in hypertension. How it is changed? More pressure is required to excrete the sodium. So that is one mechanism. Second thing is, because of chronic salt intake, there is increase in cardiac output. So when there is increase in cardiac output, body will respond. Why it will respond? So vascular beds will increase the resistance in response to hyperperfusion. So if there is some organ, for example, if you take kidney only, if suppose the blood which was coming to the kidney, it was of 40 mm of Hg, now the pressure is 80 mm of Hg. Okay, because of increased stroke volume, increased volume of blood. So that will cause damage to the organ. So in response, what that organ will do, this arterial tone, it will increase the arterial. What do you mean by increasing the arterial tone? The diameter of the arteries will decrease. So diameter of the arteries will decrease. By decreasing the diameter of the arterioles, what will happen? So less amount of blood will enter to the organs. That's how the organs preserve themselves when there is increased stroke volume due to chronic high salt intake. So but what is the detrimental effect of this? So because the tone is increased, now we remember DBP depends upon this. So DBP is increased. So diastolic blood pressure is increased. When there is increased DBP, there is increased peripheral vasculature, hence there is increased BP. There is hypertension. So what will be the outcome? What will be the outcome? High peripheral resistance with normal cardiac output is the hallmark of established hypertension. So this usually you see diastolic BP, isolated diastolic blood pressure increase in young individuals, in young individuals. Okay. Transition to high peripheral resistance with normal cardiac output is the hallmark of established hypertension. Okay. So that's how the intravascular volume and renal sodium handling. So kidney itself is increasing the BP in order to excrete the sodium. That is one thing that will cause increased BP. So the summary is kidney itself increases the BP to maintain the natriuresis. Okay. So that will cause increased BP. Second thing is, because of chronic high salt intake, increased blood volume, there is increased stroke volume. So the organs will respond to this by increasing the peripheral vascular tone, that will increase the DBP. So that's how this intravascular volume and renal sodium handling will play a role. So which are the drugs which are helpful in this scenario? The main drugs are the diuretics, and in that thiazide like diuretics. So what these will do? These will excrete the sodium, potassium, chloride, but they will preserve the calcium. They will increase the calcium. They will decrease the excretion of sodium. So there will be hyponatremia, hypokalemia, hypochloremia, hypomagnesemia, but increased magnesium. But there will be hypercalcemia. Okay, that's why thiazide like diuretics are also used in patients with recurrent renal stones. So they will reduce the formation of recurrent stones, thiazide like diuretics. So in that you have this hydrochlorothiazide. So this is the least potent. Next, chlorthalidone. So this is the second best, you can say. And the first best thiazide like diuretic is indapamide. So these will cause, so as you go from here to here, Side effects will decrease, potency will increase. Okay, potency will increase, side effects will decrease. So chlorthalidone usually in nowadays we see in all the BP medications in combination. Okay, some physicians use this indapamide. I also use this indapamide, but in renal stone patients it doesn't come in combination. You need to prescribe it separately. In combination you will have this chlorthalidone. So chlorthalidone will decrease the sodium concentration. So when sodium concentration is decreased, kidney need not means the necessary to rise the BP for natriuresis, that will be gone from the kidney. That is one thing. Second thing is there is no increased blood volume. That's why organs will not autoregulate now. Meaning the peripheral vascular resistance will not increase as a response to increased blood volume. So whole thing is getting corrected by this diuretics. So in patients with kidney failure also, you can where there is accumulation of fluid, you can prescribe furosemide or nowadays torsemide. Furosemide you need to give in TID or BD doses. Torsemide is long acting, you can give in OD dose. Okay, so that is the applied aspect. Okay, each drug will discuss in detail in a topic which will be coming further. Okay, we will have in-depth knowledge about this. Now the second mechanism is the Renin-Angiotensin-Aldosterone mechanism. Okay, so this is a very important mechanism, and these mechanisms are normal mechanisms which maintain our cardiac, which maintain our blood pressure. But these mechanisms get altered and they become detrimental in patients with hypertension. Okay, so the RAAS is an enzymatic cascade that plays a pivotal role in volume and pressure hemostasis. How we will see. So first we will see here, see this diagram. First you see this diagram. Angiotensinogen is what do you call manufactured by liver or produced by liver. Okay, when there is decreased sodium concentration, or when there is decreased blood volume, or when there is increased sympathetic activity, this renin is released from the JG apparatus, juxtaglomerular apparatus. So you will have this type of this type. Here you have a loop of Henle. Okay, and then you will have, this is the loop of Henle, and this is the collecting duct which will have proximal PCT and DCT. This is the, and here you will have this JG apparatus in between the this capsule and this apparatus. This is known as the macula densa, from where you get this renin. Okay, this macula densa produces this renin. So the stimulus is nothing but the decreased intravascular blood volume or decreased sodium concentration or due to sympathetic activity. By that, this renin is released. So this renin converts this angiotensinogen to angiotensin 1. Now this angiotensin 1, by this angiotensin converting enzyme also known as ACE, which is predominantly produced by lungs, in the vascular bed of the lungs. Predominantly it is produced by the vascular bed of the lungs. So this will convert angiotensin 1 to angiotensin 2. So this has all the things, this angiotensin 2 does all those things necessary to raise the BP. Okay, so this will there are two types of receptor for angiotensin 2, AT1 and AT2. So main receptor which is important is AT1. So angiotensin 2 will act on AT1, and AT1 receptor are also present in the adrenal mineralocorticosteroid what do you call zona fasciculata, no? Okay, so adrenal cortex will have this AT1 receptor. So at that this angiotensin 2 will act, that will cause the release of aldosterone. Okay, aldosterone what it will do, it will preserve the, it will excrete sodium, it will preserve the sodium, it will excrete the potassium, it will excrete the proton. So potassium is lost, proton is lost, sodium is preserved, volume is increased. Okay, and in addition to this, aldosterone has some other effects known as the remodeling effects. Remodeling. Okay, I will cut this. So remodeling effects aldosterone will have. So these remodeling effects are detrimental to our body. For example, hypertrophy of the heart is a very important remodeling effect which is going to happen. That's why this spironolactone, which are aldosterone agonists, are given to these patients in order to avoid this remodeling effect. Okay, avoid this remodeling. This aldosterone also has remodeling is nothing but the functional muscle fiber is replaced by the fibers, collagen fibers. So those collagen fibers have nothing work to do. Functional muscle fibers will contract and they will help in maintaining the stroke volume and cardiac output. But if you replace that by fibrous tissue, so that will not do anything, but that will cause detrimental effects. Okay, they can be a source of arrhythmia, they can be a source of sudden cardiac death, they can be a source of aneurysm, ventricular aneurysm. All these things can happen. Okay, so ventricular remodeling, hypertrophy will cause increased angina. When there is ventricular hypertrophy, so angina will develop. There is risk of MI. All these things will happen. Okay, so one thing here to say is, so see here, AC, one side it is converting angiotensin 1 to angiotensin 2, other side it is converting bradykinin to inactive peptides. So that's why when you prescribe AC, so the how we can buy. So what happens is, the thing which happens in hypertension is, so whenever there is decreased, for example, in patients with diarrhea, physiologically, when a patient comes with diarrhea and there is, or vomiting, and there is a volume loss or some hemorrhage, so this system gets activated and this system tries to maintain the BP. This is a physiological effect. Physiological effect in short term. But in hypertensive patient, in long term, this is a detrimental effect. It will cause remodeling, it will cause detrimental things. So long term it is not good, short term it will maintain the BP. That's why one information is given to all those patients which are receiving ACE inhibitors or ARBs, that they should stop temporarily the ACE inhibitors or the ARBs when they have severe diarrhea or vomiting. Why? Because this mechanism is necessary to maintain the cardiac output. And when in patients with hemorrhage or diarrhea or persistent severe vomiting, so when you prescribe ACE inhibitors or ARBs, you are suppressing this mechanism. Then how can the body increase the BP? So that's why the advice is given to all those patients who are receiving ACE inhibitors or ARBs, to stop temporarily these things for 2 to 3 days till they have their correction of blood volume. Okay, so this thing is one thing. Okay, so how we can act in long term? This becomes detrimental, this is continuously acting. So how we can act? So we can suppress the renin. So there is a drug called aliskiren, so which suppresses the renin. Okay, so aliskiren acts as this side, and as you know, there is ACE inhibitors, so they will inhibit this enzyme. So one is not converted to 2, but same thing, bradykinin will accumulate. So this is responsible for the ACE inhibitor cough. So this cough will not subside by any cough suppressant, may it be centrally acting or peripherally acting. So this is the ACE inhibitor cough. So any hypertensive patient coming with chronic cough, you should have in mind that the cough can be due to ACE inhibitor. Okay, and this will stop when you stop the ACE inhibitor and change it to ARBs. ARBs will not have this effect. Okay, meaning angiotensin receptor blockers. Okay, so here you can ACE inhibitor. Okay, now ARBs will block this receptor. Competitive inhibition, you remember the biochemistry, no? Okay, competitive inhibition, they will compete with angiotensin 2 and they will block this AT1 receptor. So no receptors are available for now for angiotensin 2. So that's why it can't act on AT1 receptor, because already ARBs are present on this AT1 receptor. So by this one thing. Now another thing is aldosterone. So what you do, you give aldosterone antagonist. Example, spironolactone. It has androgenic side effects like gynecomastia like thing. So and that's why more and more trials are now suggesting to give eplerenone. So these will not have those side effects, and this is much more powerful than spironolactone in reducing the remodeling effects. Okay, so these two drugs are aldosterone antagonist. So that's how you use these drugs in patients with hypertension. Okay, now we'll move to the table and fast we will read it fast. We need to finish this pathophysiology today. Okay, now you see here, so there is renin release which is secreted by the JG cells in afferent arteriole. Stimuli, what is the stimuli? I said low sodium, decreased renal perfusion, and sympathetic activation via beta-1 receptors which are present on JG apparatus. So this activates the RAAS cascade. RAAS cascade is another RAAS cycle which I have explained just now. So angiotensin 2 is angiotensinogen is converted to angiotensin 1, that is converted to 2 by AC. Okay, now that A2 will act on the AT1 receptor. This is important. Okay, this AT1 receptor will cause vasoconstriction, that will reach the DBP, diastolic blood pressure. This will cause the release of aldosterone. Aldosterone will increase the sodium reabsorption and increase the blood volume. Okay, in the adrenal cortex, and this will promote the sodium reabsorption in the proximal tubule. And the other thing is it will cause the release of growth factor that will cause the remodeling changes, myocardial and vascular hypertrophy. So changes in the vascular vessels, there are changes in the vessels, remodeling changes, and there are changes in the myocardium also. So similar to this angiotensin 2, aldosterone also causes these remodeling effects. That's why the AC inhibitors and ARBs, because they have uh, beneficial effects other than controlling the BP, many beneficial effects, they have become the first line nowadays, first line drugs, because of these effects only. Other than hypertension, they have beneficial effects. Okay, some ARBs like telmisartan like thing, they have metabolic, they will control the metabolic side effects also. So that's why, and they help in reducing the insulin resistance. So that's why these drugs have become the first line. So you should remember why these drugs, like telmisartan, olmesartan, irbesartan, valsartan, candesartan, all these drugs, these are ARBs, and ramipil, enalapril, or captopril, all these things. Prils are nothing but AC inhibitors, sartans are nothing but ARBs. Okay. So aldosterone is released from mineralocorticoid from adrenal cortex, and that will cause sodium reabsorption, potassium and hydrogen secretion, acts via the sodium channels in the principal cells of the cortical collecting duct. So angiotensin 2 acts on the proximal convoluted tubule, whereas aldosterone acts on the distal convoluted tubule. So that reabsorption here, sodium is in the proximal convoluted tubule. Here the reabsorption of sodium is in the distal convoluted tubule, aldosterone. Okay. Now we'll move to the next mechanism. So how does this sympathetic nervous system act now? Autonomic nervous system and sympathetic hyperactivity. So adrenergic reflexes provide rapid buffering of BP fluctuations. Remember one thing, sympathetic system will raise the BP. Parasympathetic system in general I'm saying parasympathetic system will lower the BP. How I will just explain now. Sympathetic system, it will increase the heart rate and increase the peripheral vascular resistance, whereas the parasympathetic system, nothing but the vagal nerve, they will decrease the heart rate. Okay, and by decreasing the heart rate and decreasing the peripheral vascular resistance, they will decrease the BP. In general, just remember this thing. Okay. So as you know one thing, that baro is nothing but pressure receptors are present in the carotid sinus and the aortic arc. So they sense the stretch. There is continuous tone maintained by this baroreceptor uh, uh, stretching. Okay, when there is increased pressure, meaning when there is increased hypertension, or when there is increased blood volume, so there is this is the afferent. Okay, this is the afferent. So what will be the response? Efferent response, there is decreased sympathetic outflow and increased vagal tone. So what this will cause? This will decrease the heart rate and decrease the peripheral vascular resistance. So by this they will decrease the BP. Okay, that is the function of baroreceptors. So what will happen in chronic hypertension? What will happen in chronic hypertension is, so baroreceptor will reset to a high baseline pressure. For example, baroreceptors were acting when the pressure BP was 1, BP goes to 140 by 90 in normal individuals, in normal individuals. But now in hypertension, they will reset to a high level. For example, at 170, for the sake of example, 170 by 100 or 160 by 100. So when the BP reaches at this pressure only, they will act. Below this BP, they will not act. So they will reset to a high level. That's the pathology which will happen in hypertension. Okay. Now the sympathetic overactivity. So whenever the patient is, this is seen, usually this sympathetic overactivity is seen is in essential hypertension without no cause. Okay, essential hypertension, nothing but primary hypertension. So you will find no cause, and it is genetic, meaning there will be a family history of, okay, no cause. So this is seen in patients with essential hypertension, especially those patients who have obesity and obstructive sleep apnea syndrome. This is a disease, remember, found mainly in the obese patients. Okay. Other things which modulate our BP is what. So I will explain like this. So if this is a nerve ending, which is coming, and here is our neuron which is supplying a blood vessel. Okay, so here you will have this alpha 2 receptor, and here you will have this alpha 1 receptor. So when the alpha 1 receptor is stimulated, the diameter of the artery will decrease, and there will be increased peripheral vascular resistance, and hence there will be increased BP. But when this alpha 2 is stimulated, there will be decreased release of norepinephrine. Remember, norepinephrine is a we use it in ICU patients. We use it in shock patients. That will increase the BP. So alpha 2 receptor is a presynaptic receptor. Alpha 1 receptor is a postsynaptic receptor. When you stimulate the alpha 1 receptor, it will increase the BP. But when you stimulate the alpha 2 receptor, it will decrease the release of norepinephrine, and hence it will decrease the BP. Okay, that you should remember. Okay. Same thing. Alpha 1 receptor postsynaptic smooth muscles. It will cause vasoconstriction. Alpha 2 receptor presynaptic. They provide negative feedback to limit the any release. Okay. Then the central nervous system. This is about the peripheral nervous system. Central sympathetic outflow. This is integrated in the rostral ventrolateral medulla, a part of medulla. Remember, just medulla. It is situated in the medulla, and the inputs are modulated by inputs from nucleus of tractus soleus and hypothalamus. Remember, this new NTS is actually a nucleus of vagus nerve. Okay, so the inputs come to the nucleus of tractus soleus. They will go to the hypothalamus. Okay, hypothalamus, and then to the medulla, and from there the inputs are processed, and then the BP is either increased or decreased. From the vagus nerve to the NTS, nucleus of from the NTS to the hypothalamus, then from the hypothalamus to the medulla. Okay, from the medulla to the efferents, like this. Okay, just we will have one thing here. Just see this, how this sympathetic nervous system acts. See the afferents. So afferents from the baroreceptors, afferents from the cardiopulmonary stretch receptors. Remember, there are stretch receptors in the muscle of the heart. So those stretch receptors, afferents from the skeletal muscles, again stretch receptors, and afferents from the kidney. All this from the baroreceptors, from the heart muscle, from the skeletal muscle, and from the kidney, they go by the vagus nerve to the nucleus of tractus soleus, then to the hypothalamus, and then to the medulla, from there the efferents will come. See here. See here. So this is the efferent which is coming from the medulla. Okay, so in hypothalamus you have this something called as supraoptic nucleus and paraventricular nucleus. From there you have your efferents. Now here there is nucleus of tractus soleus. You will have this vagal efferents now, and sympathetic or vagal. Though both things are there, vagal and sympathetic nervous system. So what they will do, they will modulate. So I said on previous only. So these are the efferents. Just remember the efferents: the baroreceptors, skeletal muscle, cardiac muscle, and kidney. And this is the efferent. Efferent is from the hypothalamic supraoptic nucleus and paraventricular nucleus of the hypothalamus. Efferents will go from the vagal nerve to the heart, and from the sympathetic nervous system to the skeletal muscle, releasing the norepinephrine that will act on the heart, on the arteries, on the kidney, on the adrenal cortex, and this will cause increased stroke volume, increased heart rate. This will increase the peripheral vascular resistance by sympathetic, I'm saying sympathetic nervous system, and this will cause renin release, and this will cause release of aldosterone. So these will raise the BP, whereas vagus will act only on the heart. Remember, vagus is acting only on the heart and decreases the heart rate. That's all. Okay, by decreasing the heart rate, it will decrease the BP. So how we can act by? So you have beta blockers, no? So beta blockers, and applied aspect of this is actually, I will just say, I'll remove this whole thing. Sympathetic activity. Number one is beta blockers. Number two, alpha blockers. Alpha 1 blockers. Okay, or alpha 2 agonist. Alpha 2 agonist like clonidine, centrally acting. Okay. Number three is beta blockers, alpha blockers, and number three is alpha beta blockers. Okay. For example, like carvedilol. Okay. Carvedilol is a good example for alpha beta blocker. Okay. And labetalol, which we use in emergency. So these things, what they will do, they will reduce the sympathetic activity. They will reduce the sympathetic activity and hence they will reduce the BP. Okay, that's clear. We'll move fast. Okay, time is already 36 minutes. Next thing, what is happening is, the thing which happens is the vascular remodeling and arterial stiffness. Chronic elevation of blood pressure induces profound structural changes in the arterial tree, which in turn perpetuate the hypertensive state. A concept known as reinforcement will happen. So the thing which happens is, so you have the lumen of the artery, and this is the intima of first layer, and this is the media, and this is the adventitia. Remember, there are three layers of arteries now. So this is intima, and this is media, tunica media, and this is adventitia. So normally the lumen is regulated by the smooth muscles which are present in the media. So these smooth muscles, what they will do is, in response to sympathetic or parasympathetic outflow, these will contract to reduce the lumen, or these will relax to increase the lumen. But in persistent hypertension, the thing which happens is, there is rearrangement and hypertrophy of the smooth muscles which are present in the tunica media of the arteries. What will happen is, the thing which happens is, the lumen to the wall ratio of the vessel will increase. That means this mass of the wall will increase, this mass of the wall will increase, and this lumen is reduced now. So now these arteries will lose their elasticity. Compliance they will lose. Elasticity is lost. So modulating the BP, so they will act like, for example, they become stiff. So when they become stiff, they will increase the DBP. So this is known as reinforcement. So BP increases, that will cause vascular changes. The vascular changes I have explained in the arteries, that in turn increases the BP. So we'll see here now. See here. So there are small arteries, nothing but arterioles, which maintain the DBP, and large arteries, systolic BP, like aorta, which maintain the systolic BP. Okay. So in long-term hypertension, there is remodeling. I said no, remodeling. What is that remodeling? There is rearrangement of the smooth muscle cells around a smaller lumen. So there is increased wall to lumen ratio. So what this happens? What is the consequence? Normally, the resistance vessels protects the capillaries from high pressure, but increased total peripheral resistance decreases the maximal vasodilatory capacity. So lumen, initially before remodeling, the lumen was increasing from this much to this much before remodeling, but the same lumen cannot increase to this much. It will now decrease to this much. So this is known as this remodeling causes this thing. So initially the dilation was this much, but the dilation is reduced to this much. So what this will do? This will cause the organs getting vulnerable to ischemia, because in response to increased BP or decreased BP, the arterioles are not opening that much. They should to the extent they should, because of the remodeling effects. So the organs become vulnerable to ischemia. That's why in patients, for example, with hypertensive stroke 220 BP, they will have, or in any hypertensive emergency. General thing I'm saying, in some hypertensive there is exceptions. Generally, it is said when there is hypertension, you should reduce the BP gradually. Otherwise, the tissues will get ischemia. This is the reason, because of the vascular changes, because of this autoregulation, abnormal autoregulation. Okay. This is about the small vessels. Now, talking about the big vessels, which act as, so big vessels, remember, maintain the systolic BP. So remember, when the heart pumps, when there is ventricular contraction, it will contract with the force. So this is the ventricle. If this is the ventricle and this is the aorta. Okay. So when this contracts, it will contract with a force, high force. So when there is normal elasticity of the aorta, it will stretch to like this. It will stretch, accommodating the force which is generated by the ventricles. During systole, it will stretch to from here to here. It will stretch, accommodating the force. And when the ventricle relaxes, this force is utilized during relaxation to maintain the BP, to push the blood forwards. Because of elasticity, this wall will come back and it will push the blood. So that's why during diastole, this elasticity of the large arteries like aorta plays an important role in maintaining the BP during the diastole. One thing. Another thing is, when this aorta becomes stiff, then ventricles need to generate more force in order to pump the blood. That will cause remodeling changes in the heart. So these are the detrimental consequences. Okay. So this you see in adults, usually more than 50, and this is in patient with hypertension. Okay, long-term hypertension. So because the old individuals lose their elasticity of aorta, they will have isolated systolic hypertension. We have discussed it before. Okay, so let us discuss first. So that will organs get vulnerable to ischemia in aorta. So there is normally elastic fiber, but due to age there is fragmentation of this elastic fiber, and there is calcification that will and deposition of stiffer collagen. Okay, and that process is accelerated by hyperglycemia, by diabetes. Okay, so that causes loss of Wind Kessel function. What is Wind Kessel effect? The things which I have explained just before, that the aorta will accommodate the power and it will push the blood during the diastole. That is nothing but the Wind Kessel effect. So that Wind Kessel effect is lost, causing arteries to become stiff, and which is measured by the pulse wave velocity. So that will increase the SBP. That will put the ventricles at stress and cause remodeling. So in compliant system, there is slow wave reflection, supports the coronary perfusion. But in stiff system, fast wave reflection will be there during late systole. That will increase the systolic blood pressure and the workload of the ventricles, increased left ventricular workload. Okay, so this thing is going to happen. So how do we correct these vascular things? So you give calcium channel blockers. So important. Calcium channel blockers, important. So what these calcium channel blocker will do, they will act on the smooth muscles which are present in the tunica media, and they will cause vasodilation. So that is the applied aspect, and they will cause vasodilation. Okay, so calcium channel blockers will correct this thing. Okay, coming to the last mechanism, that is nothing but genetic. We will not discuss it, but we'll discuss the important thing just. Okay, so genetic and epigenetics, the nature which is the nurture repeat. So hypertension represents a polygenic trait where a multiplicity of genetic variants interact with environmental stressors. By interacting with these environmental stressors, hypertension will occur. Because of this polygenic risk and missing heritability, there are genes, more than 100 polymorphisms which are identified. Okay, so just remember in this, heritability chance is 30 to 40%. That means 40% of chances are there in individuals whose parents or whose first degree relative had hypertension. They will also get hypertension. Okay, and there is something, this is polygenic hypertension, that is nothing but essential hypertension. So there is known as monogenic hypertension, that is rare actually. Single gene defects will cause hypertension. So the main mechanism in this monogenic hypertension is they mostly increase the renal sodium reabsorption. Okay, by that they will increase the BP. Example for that is Liddles syndrome, glucocorticoid remedial aldosteronism, and apparent mineralocorticoid excess. Okay, so more common in this, actually these are rare, but in these the more common is the Liddles syndrome, which we discuss more. So what will happen in that, there is active sodium channels in the distal tubule. They will reabsorb sodium and they will excrete the potassium. So by that they will cause volume expansion. You will have low renin and hypokalemia in these patients. That's all about the mechanisms of hypertension and the applied aspect. Okay, so one is the intravascular volume renal stone handling, RAAS, important, very important, RAAS, and the autonomic nervous system, vascular remodeling and arterial stiffness, and genetics and epigenetics. We will discuss how this hypertension causes target and damage and what measures we take. Thank you for listening. In the next class.